So thank you all for listening here after that lovely dinner. As I said, I'm Hehl. I've worked in orthopedics in the operating room for over 26 years at Hartford Hospital, level 1 trauma center. I landed in orthopedics by chance. I was looking for a job as an OR nurse, and ortho happened to be what had the opening. And I have happily been in orthopedics ever since. So first I work as a nurse scientist at the Bone Joint Institute, where I get to be active on counseling, projects, research, and education as well. Now, presumably, you are all listening today because I work in the OR, or you were told to get some CEUs, right? Or you love the OR like I do. And now, you may love the OR, you may or may not love orthopedics like that. I would like to challenge anybody that does love ortho to ask you if you have a favorite bone or not. If you have a favorite bone, I can share the tibia. I happen to think the tibia is a very elegant, sturdy bone. And I think there's some very interesting things going on in your neck, which should be frustrating for OR, but also fun. Now, having a bone, right? Also, we here to say that I also have a least favorite bone. And my least favorite bone is the tibia. Next to the talus. So the talus, right? Nobody got it. So I've spent many frustrating nights waiting and watching docs trying to get that evil ice cube of a bone back into place, right? It slips out, it takes out. And that bone is basically responsible for the title of my talk today, because I consider the talus to be one of the friskiest bones that has the potential to belong through the time. And it represents all of those fractures that lead to additional decisions, calling for more instruments, changes in the surgical fixation plan, and overall frustration in the OR. And while I am not here to teach us how to do a reduction of this risky little bone, I bring them up because their resistance and all of the other challenges have shaped how I train my nursing care in orthopedic trauma patients. When getting ready to care for an ortho trauma patient, it is very important to understand the bigger picture, right, of how they were injured and what their overall injuries are. Harder to reduce fractures, i.e. the frisky fractures, require more care and planning from the part of the nurse to make sure that we support our patients through a longer journey. So we need to support our teams not only with having everything we actually ask for, right? We have to think and have their plans B and C when plan A fails. And I believe this translates to caring for patients after surgery too, right? Understanding their mechanisms of injury and how that affects the body allows nurses to anticipate potential problems and remain vigilant in our assessment. Basic little disclosure here, I have no financial interest other than just having promoted the tibia as their So our objectives today are just going to be to take a look at refreshing your knowledge of how patients get hurt, how they experience their injuries, some of the elements of common complications, right, that nurses need to assess, plan, and know how to do for. And then I'm also going to take a little bit of time here and discuss a little bit about what it is like to be a healthcare provider who works in orthopedic trauma cases, and how sometimes that can take a toll on us too. And what we can do to help mitigate that potential for burnout or deferred trauma. So a good starting point is to remember that the orthopedic injury is damage to the bones, joints, and/or soft tissues that connect those parts. Right? Orthopedic trauma is an injury caused by something external of our bodies. And some examples include motor vehicle collisions, right? Violent attacks, paper problems, or severe falls. Another type of orthopedic injuries that we refer to as sports injuries, right? Are those that happen during sports exercise, but really can occur as a result of any repetitive or strenuous movements. So sports injuries can certainly be severe, but only rarely do they approach the definition of an orthopedic trauma. So, how do people get hurt, and what kinds of trends have been found? So to start, I took a look at our state here in Connecticut. And our Department of Health keeps data that shows that falls and vehicle-related incidents are the top two ways people get hurt in the day. Nationally, the National Safety Council, which is a nonprofit safety advocacy group, reports that in the United States, injury-related deaths have become the third leading cause of death behind only heart disease and cancer. In 2021, over 224,000 people in the United States died of preventable injuries, or we call it accidents. Said another way, this death rate was almost 68 people per 100,000 people in the United States. Scary too is the fact that this represents about a 12% increase from 2020. Maybe not surprising, right? We're kind of hiding in our houses in 2020. But more so, it's a trend that shows almost a 100% increase from 1992, which is the lowest year on record for accident deaths in the U.S., when it was only about 34 people per 100,000. Another unsettling trend that the National Highway Safety Administration reported on is that between 2009 and 2018, while the death of drivers and passengers in motor vehicle accidents have decreased, right, likely due to the improved safety engineering in our cars, right, big seatbelts, crumple zones, airbags, the death of pedestrians, on the other hand, who are struck by a car, have increased, and not necessarily the number of people getting hit, but those that get hit are dying at a higher rate. So about 14% of people in 2009 fatal accidents were hit by a car, but now it's up to about 20%. So it's sort of they're getting hit at higher speeds and more injury patterns. One last stat to talk about: the National Safety Council says that one American is accidentally injured every second, and one is killed every 3 minutes by a preventable event. So clearly, our peers, right, in public health care have their work cut out for them to find ways to influence these numbers, hopefully, to find ways to prevent these injuries and make people more aware of what we have to change. But for us, right, in the operating rooms, adding these statistics together means that we are very busy in our clinics caring for injured folks. So understanding your role in the care of the trauma patients and what you want to watch out for will be info that I hope will be useful to you. So let's start by taking a look at mechanisms, right? People gotten injured, understanding this can help us anticipate patterns and predict certain problems. If we can predict, we can increase our assessments, add additional tests and imaging so that we look for some of the hidden problems at the top. Two basic categories are low energy and high energy. Low energy injuries include categories like falls from low heights or standing height, and contact and non-contact sports. While the injury itself could be seen isolated or non-emergent, I'll let you guard that, right? Because there may be underlying medical issues that makes this patient sicker in your operating rooms. So it's important to remember low energy does not necessarily mean low risk. Conditions that leave the skeletal system susceptible to fracture include things, right, like cancer, general osteogenesis imperfecta, and osteoporosis. Patients should also be screened regularly to keep that before it might leave them out of balance, dizzy, weak, or faint. High energy mechanisms are what we typically think of when somebody has had an accident, right? These are your cars, your motorcycles, skydiving, gunshots, plane accidents, helicopters that crash, right? All kinds of things. Heights over 10 feet, like falling off a cliff or falling from a roof. So these are tricky, right? These are your typical potentially your multi-limb or systemic trauma type patients. And they may initially present looking fairly stable, but develop increasing symptoms over time. So let's talk about those frisky fractures. Some of the toughest fractures to work on, I guess we'll have to say in my opinion, are the complex pelvic fractures and segmental fractures of the long bones, right? Where they're broken into more than one place, such as venous and discs. These are typically very high levels of injury, and all of these have potential complications of muscle trauma patients. But even that aside, just the fracture itself requires some work. So first up are the pelvic fractures. So as a little bit of a reminder, the pelvis, right, ring-shaped set of bones functions together in key ways. It's helpful to think of the different zones of the pelvis when trying to understand the injury pattern that your patient has. Your pelvis is made up of paired right and left sides connected in the front, right, it's the pubis, and behind at the sacrum. Each side is made up basically of three bones, right? Your blade-shaped ilium, which is above to the side, absolutely correct. And then the pubis in the front, and the ischium is the behind part, right, where the behind is the behind. These bones all fuse together in late adolescence. Those suture lines that unite throughout the acetabulum. The acetabulum combines with the femur to make hip joints. So one nice big complex ring there. Injuries to the pelvis can involve actual fractures of those bones, or it can be what we call disruption of the pelvic ring, where they basically pull apart, they're one and more, they're partially joined areas. Worst of all, of course, can include areas of dislocation and areas that are fractured. Pelvic injuries are often categorized as stable or unstable. The unstable ones are the ones that we're going to see in our operating rooms, because they need surgery to heal. Severity of this injury will depend on which zones are dislocated or broken. The pelvis, if it is broken and dislocated in more than one location, can be considered a very unstable pattern. And the ring itself can also get torn apart, something that we call an open book pelvis. Now, one of the biggest dangers to patients from open book pelvic fractures has to do with soft tissue of our abdomen and our lower pelvic area. If we think instead of something like a broken bone, like a nice closed fracture of the humerus or of the femur, when the bone breaks, it bleeds a lot, but in a limb, blood has limited space to spill into, right? Unless it's no fractures when we're talking closed. But and when it spills into that limited area, the hematoma and the blood clot itself kind of act as a tamponade that still contain bleeding vessels on the bone. But in the pelvis, those mechanisms differ, right? Our squishy internal organs can compress up and away from the pelvic area, allowing a lot of space for blood to bleed into. Therefore, pelvic fractures can emergently lose a lot of blood from other types of those fractures. So one of the options, right, that you're going to see when you're helping to replace carry for these folks is that they might get sent to interventional radiology before coming to the OR. And there's some pretty amazing work that's done now to help with an embolization of bleeding vessels to help slow down that bleeding. Now, the embolization can be done as a definitive treatment, or it might be done just prior to bringing that patient to the OR for emergency surgeries. Additional treatments, of course, may include reduction in splinting of a badly displaced pelvic fracture by using something called a pelvic binder as an emergency tool. It can reduce the space and slow that bleeding. And also, pelvic binder reduction is a temporary fix due to the risk, right, of impaired perfusion of the So our nursing care for patients with severe pelvic fractures includes preparing for additional emergency procedures, right, such as immediate surgery to place an external fix there. These X-fixes can remain in place until the patient is out of the immediate crisis and then definitive fixation plan. The OR team should plan ahead, however, and have instrumentation immediately available to handle an open procedure, even if the surgeon has sworn they're already. So nursing actions for these cases include, think about placing the Foley before that binder is used to provide a used to position or close that pelvic fraction. Knowing how to use those binders. There's some of them have funky clips and mids and bindings, Velcro, etc. When you're finishing it, you can get it off of the legs, return blood flow to the legs, keeping your patients warm, planning for large blood loss. So planning for something like hypovolemic shock, right, high volume blood loss, might mean activating the massive transfusion protocol. So these protocols, right, include not just red blood cells, but also other blood products, such as FFP, platelets, etc. In those situations, right, being able to quickly get that protocol going is going to be a help to the integration. So, good old segmental long bone fractures. the jelly legs, right? You pick up that limb and it doesn't feel like a leg anymore. Segmental long bone fractures are often difficult to reduce, and nurses prepare, right, by anticipating additional equipment to reduce those fractures. For example, here on the left-hand side of the screen, it shows the surgeon has used a small plate with some uniformable screws that can be used as temporary fixation to connect two or more of the segments. This allows the bones to remain in alignment for the surgeon to advance the iron guide rods, ready to read them, and ultimately to place the iron rod. So these tricks, right, usually require additional sets of instruments. Our standard body set doesn't have plates and screws. So again, this is where you have a chance to look at those x-rays before you're heading into the OR. You have a young doc who just says it's an iron rod. I can see 4 or 5 pieces of humor. Like, where's also thinking, right, these messy fraction patterns may take longer. So again, you want to think about suggesting things like that holy catheter, making sure you've got your tight and straight in, think about blood loss. Post-op concerns, right, may also include that there might be extra incisions. They may have had to move that incision at the fracture site, which they may not have to move a nice little fraction. So these ideas, right, are only a tiny sliver of the types of issues that can crop up with caring for trauma patients. But one of the best approaches is to ask questions, right, and always keep learning. Look at those questions, ask your docs what you're seeing. Thinking through your mechanisms of injuries too, right? Read that patient's chart and understand it. You know, just I fell off the stage, or did I fall off the top of the roof? Right? All right. So next up, let's talk about some of these hidden problems. These can complicate recovery, right? For orthopedic injury, screened for and then either prevented or found and addressed. So regardless of what phase of care you need your patient in, the number one thing any nurse can do, right, is get that baseline assessment of the patient. Understanding your patient's current state will allow you to watch for changes that can indicate underlying problems. All right. So some of the biggest players here are these 4, right? Blood clot, blood loss, and of course, hospitalizations. Emerging evidence suggests that blood loss from both an initial orthopedic injury and from the surgery to treatment have both been reduced by the use of tranexamic acid, which has been able to be given to patients in the OR or both. I'm going to shorten that to TXA. TXA works in the body to stabilize, right, existing blood clots and therefore reduce blood loss. The bulk of the research shows that TXA does not increase the risk of thromboembolic complications. TXA has a working time in the body of only about 3 hours, and researchers are still searching for the best protocols to aid the maximum benefits of this medication for acute trauma patients. The bulk of current published evidence, right, the use of TXA has done on femurs and pelvis fractures. And the institution that I work at has begun to adopt a 4-dose protocol for hip fracture patients, which starts in the emergency department as soon as the fracture is diagnosed. These patients are screened, right, for their history of certain things like VTEs, strokes, heart attacks, or cardiac stents within the last 6 months. And if they screen okay to receive it, then 4 doses of TXA are planned. One is given immediately once that screen is okay. A second one is given 4 hours later. The third one is given at the time of surgery, and then the 4th dose is given 4 hours after the operation. We also watch patients' creatinine levels because TXA is cleared by the kidneys, and we withhold that 4th dose if their creatinine is so much high. And we have had some really interesting success with very new protocols, but we're excited to see reductions in how much blood patients are requiring in those hours. So, good old blood clots, right? Here we are worrying about TXA. Next up, blood clots, right? Orthopedic patients, we know from their long bone fractures are at increased risk for venous thromboembolism, and also because they're going to be potentially not mobile for a while, or not very mobile. So preventing these typically involves a multifaceted approach, and this includes decreasing the time that they get to surgery, right, to getting them from that PT, from their injury to the OR as quick as we can, and early mobilization. And then, of course, we want to make sure that our teams are doing good medical and Fat embolism syndrome. So we know when lung bones fracture, globules, the bone marrow, and the fat are released into the blood system. For orthopedic patients, this is usually associated with the long bones or pelvic fractures. The rate of fat embolism syndrome in orthopedic patients has been reported as up to 30% of our patients. Luckily, a lower mortality rate, but 5 to 15% of patients that do develop fat syndrome are at risk of dying. So nurses need to learn these signs as much as we can. And depending on how much and what size fat particles are released into a blood vessel, the trick is where are they deposited, right? So finding out how symptoms your patient's going to have has to be really fast. That globules have to manage. So we can see a variety of symptoms. And then the other tricky part of this is it can be anywhere from 12 to 72 hours to manifest and become apparent. Patients will typically suffer respiratory symptoms first and most severely, but ultimately they can show those other signs, things like particular hemorrhage here. And that hemorrhaging ultimately can also show up anywhere on the bodies, typically the trunk, and really can be anywhere. Some patients may show mental confusion, and some patients have been reported as complaining of a impending sense of doom. It's been described as. The patient says something like, "I just don't feel right." Can't really describe what feels wrong. In our arsenal as nurses, right, we need to maintain our ongoing assessments, encourage active floor nurses, everyone in the chain of customer patients, to don't be shy about repeating a skin assessment. You had your admission skin assessment, let's do it again 12, 24, 36 hours later to see if something like TPL hemorrhage is starting to show. And the tough part is there is no strong literal cure, right? To get at that embolism syndrome to cure, but catching it early will obviously set the patient up for more often monitoring and stronger support. So the best treatment still is limited to early fixation. So after we get the bone back together, better operations also. All right, our last treatment has been named here, acute respiratory distress syndrome. It is something that can develop and be part of that embolism syndrome, or it can also be caused by blood clots, right? Induced by vein thrombosis. Regardless of which mode of root cause problem, damage to our lungs is multifactorial. It's not just that there's a clot and the lung circuit cuts down. What they're finding now is that damage to the lungs results from the inflammation that comes from the large vessels. And those damaged cells all around an inflammation, which then lead to more fluid accumulation. And all of this is happening in all of the layers of the lungs, the interstitium as well as the alveoli cells. The result, of course, is decreased lung compliance, gas exchange, and increased pulmonary artery pressure. Treatment can require intubation to deliver adequate oxygen and to rest the lungs in invisible support. Compartment syndrome, good old compartment syndrome. This can have many causes, right? It can be acute or chronic. For us, we're talking the acute version, develops quickly and severely, and it is a true life-threatening emergency. There's very few things that get an orthopedic resident more excited than a horribly swollen compartment. The picture here, right on the left, is a swollen shiny leg with a mouth of the foot and ankle. That is your classic presentation. And that leg will feel very firm and healthy. And this is a true stat red. We're going to know. Compartment syndrome is the most common from the lower leg, following high energy material shattering fractures. It has been estimated to occur in approximately 7 of 100,000 cases in males. But interestingly, less than 1 in 100,000 females. They believe this discrepancy is likely due to the larger relative muscle mass. 75% of compartment syndrome is associated with fractures, but can also be caused by severe burns, vascular injuries, and improperly placed splits or bandages, and poor positioning during surgery. Compartments of muscles, right, become inflamed, and as different muscles swell up, their surrounding fascia is not as flexible. The area begins to then fuse off as venous outflow. Imbalance continues until the increasing pressure also then shuts down arterial flow. And this can lead to readmission like that possible place, or the now gone was it outflow. Is this working?
Is this the right one?
I think so.
Okay. I don't know why that happened.
Or it must have cut off the leaves up. All right, so again, treatment for this is going to be removal of any restricted and potentially immediate surgery where we have to slice up the compartments. Surgery is aimed at releasing the fascia and giving the area room to accommodate all of the swelling. And in severe cases, the wounds are packed open and subsequent surgery may be needed to close those wounds, to breathe the product tissue, contain the infections as they develop, and perform skin grafting. Now this doesn't work.
Now try it.
Here we go. All right. The next sneaky hidden orthopedic problem to be present are crush injuries. Right? So when patients present with mechanism of injury that includes crushing forces, this particular injury is fairly obvious, but these tend to be people that were trapped in motor vehicles, right? Weighted the motorcycle, landed on them. They may have industrial accidents, some kind of a drill press or something, falling trees, squish people, or any kind of heavy object. The extent of the damage may take time to reveal itself, so that's what makes it hidden. Assessments for this problem also will include watching for changes, elevate the limb to decrease fluid buildup, unless compartment syndrome is also suspected, and we keep it at the heart level and don't raise it up. We also usually want to treat these patients with high amounts of iron crystalloids, right, to increase their urine output and help them excrete all the myoglobin that's being released from damaged tissues. Quite often, these patients will require multiple surgeries to cleanse their open wounds, treat their product tissue, and potentially even staged amputations. So, those are our basic things. But when discussing hidden problems of ortho trauma patients are this type, we must also include mental health considerations. For those of us in the acute phase of the trauma, care of the trauma patient, this may not seem to be high on our priorities in the algorithms, but it is important to understand what an acute trauma can mean to our patient's mental health, including issues like forming PTSD, acute depression, and all of those things can affect how they perceive pain and how they will respond to medications and their overall trajectory of life. Researchers now understand that it is important to remember that how patients experience their injuries and the potentially traumatic event that caused them can be affected by combinations of social, psychological, and biological factors. The American College of Surgeons considers it essential to treat trauma patients right in the evening, right, for psychiatric and substance abuse issues. But sometimes those screenings can be awkward and long. I found an interesting article that describes some researchers that have developed screening tools specifically designed for the acute trauma setting. They put down the screens to 4 questions that nurses either in the right or an preoperative, depending on who's caring for them, can ask, and these questions show a strong correlation to development and PTSD development. First question is, were other people injured in this accident, injured or killed? Does the patient have children? I think that makes a lot of people stressed. Did the patient perceive that they might die? Did they feel at any point during the accident that they were going to die? And how long would they ultimately have to be in the care of the trauma? This 4-item screening could help, right? Could help healthcare providers determine who's at higher risk. And if we can figure out who's at higher risk, we can hopefully figure out earlier interventions and add additional follow-up care and more closely monitor patients' progress. One of the best tips we can do to help our patients is to talk to them. Researchers have shown that healthcare providers who ask patients about their fears, worries, and things that might sound depressing are able to intervene in a more timely manner. And, you know, of course, for us in a periop setting, one of the challenges is making sure that you're aware of potential resources or helping to make connections for the patients in their next setting. We're not going to bring psychologists to pre-op, but we could at least make a note and answer their calls. It's should be on all of our radar and to watch out for the mental health complications and learn different ways to help our patients. And that starts with looking for those issues, right, and using those appropriate screening tools. So one possible intervention, right, would be to do something pretty simple called emotional check-in, right? Even if the patient didn't score high on something like a PTSD risk scale, it is still considered important to think about their emotions and how the stress can affect them. By directly discussing the patient's emotions, we may be able to help our patients have a smoother surgery and possibly then a smoother recovery. Research demonstrates that how patients feel emotionally will affect their tolerance right down the road for activities, for helping us with their care, also their pain levels. And also we know, I'm sure we all know, patients can experience emotions that are disproportionate to their actual injuries. So we don't want to assume just because it's a little ankle fracture that we don't have to ask them. We know we have to ask them. So while there are these amazing questionnaires, screening tools, and things like that, research still suggests that we need to rely on our own assessments and ultimately just be willing to ask patients and be willing to listen to their answers. This is called that emotional check-in, and nurses simply ask the patient to describe what are you worried about right now. And I bet you all that experiences in pre-op, right? Just saying, seeing the crying patient and just sort of pause for a moment, you know, from our 2-minute check-in, make it a 3-minute, and ask them. We don't necessarily have to have all of the answers, but it is that first chance to just be that caring and concerning person and offering that check-in. The last topic I wanted to discuss with you guys today has to do with us, the healthcare team. It might sound like my profile as ORNers, right, to bring up mental health considerations of the healthcare team. Or it might risk sounding trendy, right, due to the rising interest in related research that has lots of folks looking at nurse and provider burnout post-COVID world. But I still want to share a little bit about my own experiences of working in orthopedic trauma arena for the past 25 years. And as much as I love my work, I am finding all the time that I have cases that stick with me much more than they ever used to do when I first started. I've even had trouble sleeping, and I've had flashbacks. I had experiences where I vividly remember the images of a mangled limb that I saw in AORN, or I've had perseverating memories of the feel of a badly mangled, segmentally fractured leg. Literally, as it wobbled in my hands as they got ready for the surgical prep. And I've had some trouble shaking off these memories in day-to-day life. And that led me to sort of look up, like read up on what this phenomenon is. And I found a lot of information on secondary trauma, and that we as healthcare providers maybe have to look at ourselves through some of this stuff. So what I learned about this is that many of us, right, find it very exciting to be a part of the trauma team. Whether your work is the ED, the OR, the inpatient units, or ultimately helping patients plan for their transitions of care, we get to feel professionally challenged, right? It's exciting. We get to use all of our skills and also feel very connected to a team of like-minded providers working together in this very, very focused time. But this high adrenaline atmosphere can also have a scary side. Through this kind of work, we are witnesses to some of the most frightening injuries, to heightened emotions, and dire circumstances. Sometimes it can be difficult to get an image on your mind or to shake off the feeling that you could have done more or been better prepared. Researchers have recently reported that nurses, right, have a high rate of suicide in the general population. What the heck? Too much exposure to this type of work can lead to anxiety, secondary trauma, and even PTSD. And of course, the compassion fatigue, also known as burnout. Burnout, of course, is estimated to occur in 18 to 30% of nurses, and should definitely be something that we are all paying attention to. It is therefore important to examine ways to help build better systems, right? Help build better OR teams to help address this type of secondary trauma. So I would like to suggest, and research has suggested, team debriefing, might be one small way to help. Researchers have shown that secondary traumatic stress can be treated, of course, with traditional things like exposure therapy, right? Going to talk to a therapist, or group therapy. So getting formal help for symptoms is always an option if you're feeling scared or worried. But I, and a lot of researchers think it's also important to try to actually prevent, right? Prevent or mitigate the effects that exposure to traumatic events can have. And that one way to do that is to incorporate proactive debriefing. So for this, we would need to build in debriefs as part of our expected workflow. This can be customized by teams to meet their unit's particulars. But this is a process that can help us connect as a team after difficult cases. Things like rapid responses or codes or the trauma cases in our ORs. Team debriefings have the potential to improve our team functioning too. It's kind of a win-win. It allows the team to discuss the actual workflow and critique their steps. But more importantly, this gives time for psychological first aid, right? Psychological first aid includes taking a little time to process events. It allows us to use self-reflection, think about how you feel, and then it allows us to ask other people and then listen to their concerns and worries too. It can be as simple as getting a group together and just around the circle, how are you doing? Do you have any questions or concerns about the case, code, event that you're all just working on? Team members will benefit from this time that gives them that moment to self-reflect. Again, and those critiques of the team's performance. Also, if you then discover, yes, how you're feeling, right? If you discover that someone is struggling, they then immediately refer to employee assistance resources rather than waiting until later. Debriefing right after the event also allows time that team members are able to jump back into the rest of their shift. Then they jump right back into providing care for the next patient, or recognize maybe they need to have an additional break when we give them a little bit of time. Building on the evidence that trauma cases and negative critical events should trigger debriefing, institutions, departments, and divisions in our hospitals can identify specific types of events that should prompt a member of the team to offer a debriefing. And hopefully we can get to the point where specific team leaders, should be trained in communication techniques to help run these debriefs. And they should be quick meetings, You're not talking about 3 hours on that. Individual facilities can decide if debriefings should be long or short, informal or formal, but they are best, research tells us, when they occur as close to the event as possible. Features of the debrief also should include some training of those leaders, an atmosphere free of judgment, and they should ideally include the whole team. Teams should learn from events and not try to look for people or actions to blame, and team leaders should also encourage all members to contribute and ask questions. Because it can be the quiet one in the corner, that might be suffering the most, so you do want to get everything. So ultimately, thank you very much for listening, So taking care of your organization. Thank you, everyone.
Thank you.